Hello, everybody. We are back and we have for you guys Melissa Lodge. We are super excited to have Melissa with us today. We're going to talk about all things research and what she's got going on in the research world regarding REDs. So if you guys are familiar with that, and LEA or low energy availability. But thank you so much for joining us today, Melissa.
Yeah, thanks for having me.
We are excited. Melissa's been briefed on the two truths and a lie. So we're excited to dive into those, but I think you should share. Do you want to share what you shared with us just before we hit record about your past two truths and a lie experience?
Yeah, I'm always very bad at playing this game because I'm honest to a fault. So I often catch myself telling three truths, but I do have two truths and a lie for you today.
Okay, perfect.
So I'll read them off here.
Okay.
First one is I was a footwear model. The
Okay.
second is I've run 4:34 in the mile, so 4
Okay.
minutes and 34 seconds.
Wow.
And then I've run on all seven continents.
Okay. Okay. I mean, I know you're a runner. We've done our research there, so I know. But I mean, all of these could be run related. Footwear could be running shoe related. 4:34 mile. That is smoking fast. That is, oh my goodness. I wish I could run a 4:34 mile. That's
Wish I could run
amazing.
like 7:34 miles.
Yeah. Um, I kind of think maybe like Amanda has said in our two truths in the past is like maybe it's not a 4:34 mile, maybe it's like 4:36 or like, maybe there's some just like little number swapping going on there. I think I'm gonna go with that one as a lie. I like feel like you're really fast, but I feel like maybe there's just like some wiggle room with like the seconds there or something. What do you think, Amanda?
I'm gonna go with the all seven continents.
That's a good one.
Like maybe it's 6.
So we both think you're a footwear model or one of the
I can
footwear
see that.
models.
Yeah,
Yeah.
I can
You
see
can
that.
only see me from the shoulders up today,
Yeah,
so
but we're sure
you can't
you have
tell.
great feet. Like, yeah.
I'm sure in your fast smile,
Yeah,
getting that.
exactly. Well, we'll reveal the answer for the listeners at the end, and see was Melissa a footwear model or not, and was she or is she incredibly fast at the mile and has ran on all seven continents or not? Why don't you break it down for us, Melissa? What got you excited and drawn to one research with regards to physiology, but then specifically in the red S and LEA population and area?
Yeah. So I don't know if you've heard this term thrown around before with other researchers in this space. We use it a lot that research is me search. And so I was always really interested in physiology in some capacity. I had my grandparents, three of them were medical doctors. So I was always really interested in like how the body works. And as an athlete, you kind of focus a little bit more on how exercise affects your body. And through my undergraduate experience, I wasn't really sure like where that was going to lead me or what specifically I wanted to focus on. And so as most students do, you test some things out, you shadow some doctors, you think maybe physical therapy, you think maybe physician assistant. I went through all of these different, roundabout ways. And really I have such a respect for clinicians. But what I was finding more and more, and through my own experience with injuries and trying to solve what was going on with myself as an athlete, I really realized there was so few answers to the questions that I had, and that clinicians were only able to answer within the realm of the research that we have available to us. So it really highlighted that gap. And so I thought, oh, well, I've never really thought about it that way. Like maybe this is my opportunity to help and contribute to this field. And so while that was bubbling on the surface, I still was like, oh shoot, I'm graduating. I don't actually know what I want to do. And I had more eligibility in the NCAA. So I took my first year of my master's program where I did a master's in exercise science to kind
Mhm.
of figure out if research really was the spot for me. And till some time finish up my eligibility, I realized that, wow, this actually really does light me up. I like asking questions. I like finding the answers to these questions. I like being able to still interact with the clinicians and benefit the athlete, but kind of in this more like full circle or, more holistic approach where I wasn't just sitting down with an athlete, kind of telling them the same things every day or
Mhm.
treating like the same injury with a different person and kind of having to go through that iterative process.
Mhm.
So I really found that it was quite dynamic. I got experience teaching alongside of my research, and I really like interacting with students and helping them figure out what they're passionate about and maybe like alternative ways to be involved in the field. So that's, maybe a short answer long, but really just through experience and in realizing all the gaps in the research and in wanting to be somebody that helps fill those gaps.
I think that's amazing. The research is me search is a great yeah, great line. I tell Amanda that a lot of these podcast interviews too are like selfishly, I'm just curious to like talk to you, like, because I want to learn these things. I'm sure our listeners, of course, I mean, they like to hear it too, but yeah, that's selfishly. So you mentioned that with the regards to the research is me search, having experienced some issues, you said with injuries through your sporting, what kind of recommendations at the time were you getting, or solutions or not, from your physicians then? Was it just not a lot of information, or?
Yeah, no, so it's actually quite interesting. I was super lucky. I grew up right outside of Boston, so we had the female athlete program at Boston Children's Hospital
Yes.
just in our backyard, right? And so
Amazing.
it wasn't even something necessarily that we sought out. That
Mm,
was just who you went to go see. That was the sports medicine physician that
great.
other people had been to, and of course, that's Dr. Catherine Ackerman. So she put these pieces together for me.
Yeah.
At the time when I was in high school, I always kind of joke when um, athletes share their experience and they're like, nobody ever diagnosed me with REDs.
Mm,
And sometimes you kind of ask, like, oh, when were you going through these issues? And if it's prior to 2014, we didn't even use that
right.
term. So,
Yeah.
she connected the dots with what we used to focus on being the female athlete triad with the menstrual dysfunction,
Mm,
the low bone mineral density,
hmm.
and the low energy availability piece.
Mm,
And when she saw me for my stress fractures, I was there to just help me heal the bone, let me get back on track, and we'll be good to go. But she
mhm,
was connecting the dots, and she saw what I didn't see at the time, or that I didn't want to hear necessarily, right, when I was a bit younger. And so that took a long time for me to really learn the lessons that she was trying to teach me. I think clinicians would probably be nodding their heads along like, yep, we see people make the same mistake. We treat the same thing multiple times until
mm,
somebody gets the message. So it took me years, honestly,
mm,
too long. But in college, I still continued to see her, and we learned a little bit more about relative energy deficiency in sport. And so these things were on my radar as a student of something I wanted to learn more about. And then the athletic piece for me was really what tied it together of wanting to resolve these issues surrounding the low energy availability because it was really impeding my performance. And so
mhm.
I know you've talked about REDs on the podcast before, but if your listeners aren't familiar, there's the health conceptual model and the performance conceptual model of REDs. And oftentimes the performance model is what gets a lot of athletes or coaches on board,
Mm,
because a lot of us are really short sighted in that our bone health is super, super important, but we have to prioritize it in our adolescence, in our teens. And there's not many teenagers that are concerned about their bone health when they're 70. That's when it's truly going to
yeah.
have the most long-term impact. And so for somebody like myself, I was probably in that same boat with other health consequences, knowing, that I wanted to resolve the bone stress injury, but only to get me back to my sport, not to um, protect myself as an 80-year-old grandma necessarily. And those performance outcomes are really something that we can use as a carrot for patients or participants to help improve the buy-in and to help resolve some of the underlying issues, because that helps them now and it helps them through a performance lens. So I always kind of say that health first, performance second is really health and performance first. Like you can't have one without the other, but it's just the way that you frame it for people, I think is what can change their minds about their approach to treatment or their approach to prevention.
Yeah, that's great. Can you, for the listeners, kind of break down, you mentioned the two different models, the health and performance. You mentioned bone density being one of the things from a health perspective. What are some of the other markers or things someone should keep an eye out for with regards to health? And then if you could share also some of the performance signs as well.
Yeah, so as I alluded to, Relative Energy Deficiency in Sport was first published in 2014 by the International Olympic Committee, and it contains 10 health and 10 performance consequences. But recently in 2023, they had an updated consensus. So they updated in 2018, but those models didn't change until 2023. And really what they show is the effects of that low energy availability, which does exist on a continuum. So as I'm going through these, this might not be something that everyone checks off every single box, but it's like a constellation of outcomes that are adverse and might be more severe in some cases than others, depending on what that exposure to low energy availability looks like. So some of the key ones that come from the original triad statement that was published by the American College of Sports Medicine that have stayed in the model all along was the impaired reproductive function and the impaired bone health. REDs does highlight that these consequences exist in males and females in all athletic and exercising populations, but those two have really demonstrated the strongest relationship in the literature. The impaired reproductive function, so think about things like menstrual cycle dysfunction, low testosterone, impaired bone health. With athletes, we really often see this starts as bone stress injuries. So they're reporting to the clinic because of that rather than necessarily knowing that they have low bone mineral density, but that could follow if there's a high risk bone stress injury. So bone stress injuries that are considered high risk, the research still debates exactly how to categorize high risk, but the IOC mentions the sacrum, the pelvis, and the femoral neck as these high risk areas. So those require significant workup and potentially a bone mineral density scan to understand maybe why that bone stress injury occurred. Other things you asked about: impaired GI function, so gastrointestinal function, bloating, nauseousness, like general GI distress in and around exercise, and then impaired energy metabolism and regulation. So we see that resting metabolic rate tends to decrease in order to try to keep systems on board with as little energy as somebody's providing the system. And then some of those like thyroid markers that are really common that we see, like T3 and T4, and then impaired hematological function. So a lot of athletes might experience something like iron deficiency, but all of these like red blood cell markers, like ferritin, hemoglobin, things like that. Urinary incontinence is one that was added in 2023.
Interesting.
This has had some emerging links to low energy availability, but it's all been more cross-sectional. And so there's a lot more work to be done here. And then impaired glucose and lipid metabolism, they kind of separated this in the recent 2023 consensus, but looking more specifically at how glucose and lipids are being metabolized, it has obviously consequences based off of what that energy intake looks like from carbohydrates, fats, protein. And then they've changed a couple of the terms. So something like psychological outcomes are now mental health issues, which in the model, you might see that this arrow actually goes both ways,
Mm.
which might not surprise people in the sense that there's a lot of psychological comorbidities, things like depression, anxiety, that can precede or become a result of the low energy availability. And that's why it's really important to have a multidisciplinary team on board that can handle all of these challenges, right? They're far reaching. Things like impaired neurocognitive function, I'll kind of breeze through the other ones, but sleep disturbances, impaired cardiovascular function, reduced skeletal muscle function, impaired growth and development for the adolescent athletes, and then reduced immunity. So increased risk of like upper respiratory tract infections, things that are either persistent or chronic as far as like immune markers.
Mm.
So they've really expanded. There's, I think, about 14 of them, if I
Wow.
can count, that have all been recently added to the health conceptual model. And then what I like to highlight with the performance is it actually looks like it's less. It's not 10 anymore. They've synthesized it to 8, but really it's just they've made bigger buckets. So it's not that there's these consequences that no longer exist, but for example, we used to see it defined as increased risk of injury, or I don't remember if illness was on the performance as well, but essentially now it's decreased athlete availability, lost days of training or competition due to a variety of circumstances. And we know, particularly in the endurance world, that time away from training has super grave consequences for performance. So these are things like unscheduled days off. So I want to be clear there, like rest is important, but when you're not able to train due to extenuating circumstances that might be a result of low energy availability, that's where we can get into trouble with performance outcomes. And then we also see that athletes in a state of REDs are going to experience things like decreased training response. So they're not getting the same bang for their buck for their training, decreased recovery. So obviously we know that recovery has immense impact on performance. So if we're not able to recover between those sessions, then we're not able to benefit, and we're kind of not getting that upwards trajectory. We're not able to come back from those hard sessions. So we keep dipping lower and lower. So our performance suffers as a result. And then decreased cognitive performance and skill. Obviously, that has stronger implications for different sport types, but cognitive performance matters no matter what sport you compete in. And then we're seeing things like, from a mood standpoint, decreased motivation for training, for competition, decreased muscle strength, decreased endurance performance, and decreased power performance. So those could all kind of be something that an athlete across a variety of sports would be concerned with. But you can kind of see how those bigger buckets, it could be that the specific outcome could be grouped within one of these bigger buckets, but all of them could be something that arise due to a state of REDs.
Wow. Yeah. That's quite the list too. I think like you're saying, like the
Right.
performance stuff, the motivation to train is an interesting one, because I feel like athletes at such a high level are probably used to just like going and training anyways, and maybe they were at that point, who knows? But yeah, that's I always think that is an interesting area to look into as well. But okay, so I do want to cover some of your research. So a lot of your research goes into and is about the knowledge of certain situations, knowledge of triad, knowledge of RED-S. So, I mean, I think that's at least a unique area that I have seen with regards to research, and looking into, and correct me if I'm wrong here, but you're looking into the knowledge of these RED-S among coaches, right? And maybe practitioners and clinicians as well, or kind of break that down for us. Share us kind of how you're looking into that.
Yeah, definitely. So while obviously all of those consequences I just mentioned are super important to keep in mind in identifying the cause of low energy availability and the outcomes that they're suffering from in order to resolve the adverse health or performance outcomes that are appearing within a certain athlete, that's super important. It's essential to the treatment strategy. We do have recommendations that have persisted over time. So from the female athlete triad through all of the REDS position statements, the prevention of REDs has focused on the use of educational strategies. This has been a persisting recommendation, but there's been very little that's been done to understand what that could look like and how effective it is. And so we really need a lot more work there. And in order to really know where that work leads us or where we need to pick up is to understand where we are. And so what does the knowledge of these conditions look like? And so my early work focused on just assessing the knowledge of these conditions in cross-country athletes in particular, and then their support staff, so coaches and athletic trainers, looking more so at the NCAA system where these people that surround the athlete are highly available to them, and that they have really, if not daily interactions, really frequent interactions with the athlete. So they have the ability to maybe identify these outcomes or screen for certain things. And so with that, understanding what the current state of their knowledge is in order to know what gaps we need to fill is super important. And there had been some early work, and there's still some that since this original paper that I published has come out on just general sports nutrition knowledge and risk for low energy availability. So the relationship is quite interesting here in that what we're seeing in the emerging literature is that those with higher levels of sports nutrition knowledge actually have an increased risk of low energy availability, which might be at odds for what people would expect. You think, oh, well, if they're not fueling properly, they might not know enough. And now these are surveys and it's cross-sectional. So definitely more work to be done if people are maybe educated in the right ways or have the right behavior change tools. But this is telling us that those who are at risk actually maybe their knowledge is okay, but or the method in which they received the knowledge would be the problem. So things like social media or not being able to identify like what are evidence-based or reputable sources. So I took that as an opportunity to look at, okay, well, that's sports nutrition knowledge. And when we're looking at the sports nutrition basics, a lot of the times it doesn't really necessarily cover what happens if you don't meet the recommendations. And so that is really interesting to me as an athlete who, if you're trying to optimize, you want to know what you're also trying to prevent. And so while you might not resonate with, oh, you need X amount of grams of protein after your workout, it might be more so the messaging that you need to hit these benchmarks in order to prevent the slew of health and performance consequences. And again, using that performance as the carrot. So a little off topic here, but essentially that led me to one of the papers out of this data set that we were really just actually trying to assess the knowledge of the female athlete triad and relative energy deficiency in sport in the athletes, the coaches, and the athletic trainers. And what we did here, we actually took a method that had been used previously to just assess the female athlete triad in athletic trainers. And what we did is we asked them a slew of knowledge questions. So it was 37 questions, all focused on low energy availability related conditions and how it occurs and what signs and symptoms are, like do's and don'ts. And they not only responded to the knowledge questions as like you would when you're just answering a test, but we had them rank their confidence in their answer. So I liked this. I'd seen it previously done, and I liked this idea in the sporting population that not only do we care about their knowledge, but we want to know what they're potentially doing with it. And so we use this confidence measure as a proxy for that. So we do know that people who are more confident in what they know are going to be more likely to share that information. Now, I do fear that that actually might be changing given the landscape of social media, but that might be a problem for another time. And what I was also really curious about with this measure is those that had low knowledge but high confidence could be the most dangerous people. And that they would be they'd be confident enough to share the incorrect information. And so we use those two scores to calculate what we called an educational impact score. So that really told us about not only their knowledge, but their confidence. So we factored those scores together to tell us a little bit more of the story. Would they be likely to share that knowledge if they got the answer correct, but they weren't really confident? It's like, well, to us, that didn't really signify that they really knew the information because they weren't confident enough in their answer, and that they would potentially not be disseminating that information, because if you're less likely to be confident in that information, you probably aren't likely to share it with your teammates, with, if you're the coach, with your athletes, or with the athletic trainers, being the athletes as their patients. So that was our approach. And then if you want to get into some of the significant findings, we can dive into what we found.
I have one question about the assessment. So was this like a test, like a multiple choice, or was it like a yes, no? I've like know of the symptoms of RED-S, or how were they structured?
Yeah, so first, actually, we did ask them before they dove into the knowledge piece whether or not they had heard of the conditions. We are seeing that if that question has been used either in our study or a variety of, asked in a slightly different way, but in a variety of studies, that number is increasing. So the awareness has improved over time.
Awesome.
But then once we got into the knowledge piece of the questionnaire, they were answering, similar to like a test format, but we structured it in several different ways in order to kind of provide them with different structured questions, so that if you can remember from school, you're not a test taker, and you might not do so well with certain questions, or we might have reframed them in a different way. So we had multiple choice questions, we had like multi-select questions, and they did like true false. They were also allowed, I should say, they were allowed to select don't know. And so we scored this as 0. If they got the correct answer, we scored that as 1. And then if they got the wrong answer, we actually subtracted a point. So their score could range from -37 to 37. But then of course we factored in that knowledge, or that confidence piece, which they ranked from 0 to 4. And based off of that confidence factor, their educational impact score reflected that same knowledge range of scores, so -37 to 37.
Wow, this is very interesting. So yeah, definitely would love. So what kind of things did you come away with and find from your results?
Yeah, so in this particular sample, we did see that our female cross-country athletes, so they were college athletes, and they had the lowest scores across the board, whether it be knowledge, confidence, or that educational impact. And they were significantly lower than the coaches and the athletic trainers. But the coaches and athletic trainers actually did not differ significantly in their knowledge, confidence, or educational impact scores. The piece here is that obviously those that are coaches or athletic trainers ideally would have a higher level of knowledge. So that could be seen as a positive finding. Although we do still see that there's improvement to be made with the actual scores themselves. So unfortunately, since we created this survey, there aren't necessarily reference values to say they're sufficient, this is poor, or like below average. We don't have reference ranges, but it is insightful that we might need to do more work with the athletic population as well, because while coaches and athletic trainers might hold the keys, I really would like everyone to have a sufficient amount of knowledge. We do
Mhm.
want to make sure that athletes understand these conditions and can stand up for themselves should they need to, that they can seek treatment should they need to. So while it's good that coaches and athletic trainers do have a higher level, overall, we'd like to see that that is improved for all of the populations that we studied.
Yeah. Wow. And so kind of looking at that information you gathered, what would you like to see kind of moving forward, or what's your vision and hopes for continuing the education piece for the athletes as well as the trainers? Is there going to be a baseline certification test that they need to pass from the athletic trainer perspective to like gauge these things to look out for, or I don't know, like a baseline education like video that the athletes need to do each year, or where do you see that going?
Yeah, that's kind of where we're headed next. I think as far as each specific subpopulation, really what this highlights is that we do need to frame a education or knowledge improvement as preventative.
Hmm.
So there's still going to obviously be individuals who can have a high level of knowledge, like we've seen with sports nutrition knowledge, and still suffer from these conditions. But from a population wide standpoint, if we focus on education, then we will have better outcomes as far as prevention and then resources for those who are suffering from
Hmm.
these conditions, regardless of their knowledge. And coaches and athletic trainers sit in a very different place than the athletes do. So I really think that coaches and athletic trainers do need some form of formal training on these conditions in particular because of their contact with the athlete. They stand in a position where they're actually able to help us refer to providers who can provide them with more clinical one-on-one care. And those individuals will ideally have more of a focus on these conditions. So, for example, in the NCAA, there's plenty of athletic trainers across institutions. And do we expect all of them to be experts in REDs? No. But do we want them to be able to recognize the key signs and symptoms and screen every athlete properly so that those athletes can be referred out to whatever member of the multidisciplinary team they need to in order to get the proper treatment? So I kind of mentioned the mental health issues earlier. That's a big one. And if we need an athlete that has psychological symptoms or other comorbidities happening alongside of REDs, they need not only mental health treatment, but they might also need that registered dietitian to help them get their energy availability to a optimal or adequate zone. They also might need some form of a physician to check in with certain REDS outcomes. Think about like the reproductive function or the bone mineral density. So we refer to these people as like a multidisciplinary or interdisciplinary team. And so the athletic trainer certainly is not going to be able to do all of those things. We don't expect them to, but they stand in a really unique position where they have regular contact with the athlete and they also have the ability to screen them, which is something that I think is a really, really powerful thing that we need to work on in some of our either at the institution level or at the organization based level. And then similar with the coaches, since they have that daily contact, they also have a really high degree of influence on the athlete. So even more so than the athletic trainer, while they might not be able to do the formal referring, they can encourage athletes to go see the athletic trainer or to go see a physician. But they really have the keys that we need in order to connect with the athlete. And they have that communication already established and that rapport, ideally a positive rapport already established. And they also do, unfortunately, on the other side of the coin, hold the keys to not supporting this whole process. So we could have an athlete who is suffering, knows they're suffering, needs help, and a coach isn't really supportive of that. They're either performing well or they just don't see the athlete as this holistic person. And so they can really stand in the way. And so that's where we need to do a lot of the education with the coach, is to ensure that the coach understands that we're a part of that team, that we're not trying to stand in the way of the athlete or the coach doing their job, but that we're there to support and do it in a healthy way. And that would ultimately help their performance. So I really think that the coaches are a population that we need to spend more time on because of that rapport, because of their influence on the athlete themselves. But then obviously one level further, we can't leave the athletes out of the equation. They're the ones that are suffering from the outcomes. They're the ones that are going to either deal with these consequences in the short or long term. And they need the tools to be able to decide what they need to do and whether or not that's in conflict, ideally not in conflict with their coach or their athletic trainer, but if it is, that they can seek the attention or the care that they need, should they choose to do so.
Amazing. And you mentioned a few times the athletic trainers doing a screening. Is that like where they sit down with each athlete individually and ask them a series of questions? Do they send them home with a self-survey? Is this happening yet? Or is this kind of a vision and a hopes that we want to see happening?
Probably some combination of all of the above. The recent BGSM issue on REDs in 2023 had an update on the clinical assessment tool as well. And so this is our best model for how we could integrate this into, let's say, the collegiate setting, which is a population I work with more extensively. And what that would look like is kind of this 3-step process where we screen, then we assess those high-risk athletes based off of the screening, and proceed for clinical diagnosis and a treatment plan. So whether or not that has implications for their training or their competition, and what to do and how we reintegrate them back to their sport. But we'll focus on step 1 because I think that this is really important because it's more population wide. It's easy to implement. And it is implemented at some institutions. From whether or not it's from this REDS lens is up for debate. A lot of them do it more so for eating disorders or disordered eating, but that's also necessary. And so really what we would like to see, or what I've seen recommended, is to keep those eating disorder screenings. We absolutely need those, but they might not catch everyone. And so adding something that maybe targets low energy availability or REDs in a more nuanced way that you might not catch on an eating disorder screen. And so the IOC does have a list of recommended screenings, and we could maybe link that for listeners that would be interested in helping integrate this maybe where they are. And so what that looks like is most of these screeners are self-report. And whether or not they're administered either by the athletic trainer or like online or paper copies, everyone does it slightly differently. Ideally, what we would like to see, though, is if we are implementing it, let's say with the college population, and they're coming back for preseason, we'd want to make sure that they're taking it in an environment that's supportive. And so that would look like, not sending it out prior to them getting on campus, where we could provide them with the necessary resources that are available to us. That's a little bit of a tangent, but if somebody is listening who has the ability to put this into practice, that would be one of the recommendations as well. And so these surveys will really categorize these athletes, most of the time high and low, but sometimes there's like three categories that might be, no risk, medium risk, and high risk, or approaching high risk. And so these screeners are really useful in order to understand who we need to do more objective assessments on. If you have somebody who's screening quite low risk, it might not be worth the while or worth the resource to get their DEXA done for a bone mineral density scan, might not be worth doing a blood draw to get their hematological function, so on and so forth. So if we see that there's a lot of low risk individuals, then we can monitor. We can check back in either the following season, the following year. A lot of the times these, the protocols that I've seen, particularly at the university level, often screen first years, but don't have any requirements beyond that. And we obviously know that college is a really pivotal time, especially for some of these conditions, to develop. And so I think that it's a missed opportunity to not screen at least yearly, if not more often. But those who do often will catch, freshmen. That being said, they often only will use one screener. And this is why we recommend two, is because they could report with different signs and symptoms, or the screener that you use might be less sensitive to certain things. So they might have a higher cutoff for something like an eating disorder, whereas our red screener would catch maybe more people. And so whether or not they screen high risk on any of those assessments would be warranting a further workup, whether that happens just with the athletic training team or requires referral, would probably depend on the institution. But this is a really easy way to screen a population so big as like your student athletes, in order to understand like who might need to see other providers and what other assessments really need to take place, because this knowledge piece is going to help with prevention, but it might not help with this piece of understanding what signs and symptoms are related to their risk. So I'm really interested in the knowledge as a vehicle for prevention, and using that as a tool to see if we can reduce risk rather than in the moment once they're presenting with those signs and symptoms, more so before the signs and symptoms develop.
Yeah, that's great. I think that's a super helpful tool. And you said that those are was that in the IOC article, the screening? Okay, we'll link that in the show notes.
Yeah, the
for our
clinical assessment
listeners.
tool.
Okay, awesome. And then let's see, I want to make sure we are mindful of your time. So I do want to ask you one last question, and then we can figure out your two truths and a lie. But where do you see REDs and LEA research going right now in the coming 5-10 years?
Yeah, so I mean, maybe this is selfishly, but I also do think that this is based off of where we are headed. And that's that a lot of research focuses first on this cross-sectional work. How do we know that it's a problem? What things are associated with this problem? The early goings can be a lot of this prevalence work, and can be a lot of identifying certain signs and symptoms that might be strongly or weakly correlated with the condition. And now that we've done some of that, and some of it, done a lot of that, we really need a lot more intervention-based work, a lot of longitudinal work to help support what we found cross-sectionally. And that's across the board. So, my focus being knowledge, being these preventative efforts. I would really like to be able to tell a lot people more evidence-based recommendations for what we can do or what's been supported in certain populations, rather than just saying that this is a problem and this is what it could lead to. Both are important. And really understanding what the short and long-term outcomes are, because some of them, like, for example, urinary incontinence is a newer health outcome that has been found to be linked with low energy availability in REDs, but there's not a lot of, let's say, longitudinal work to understand what the time course of it is, what the resolution of those outcomes are. And so I think that there is some work to be done with each of these outcomes as far as the recovery of the low energy availability and what that has from a treatment standpoint, or what treatment outcomes come online as a result. So the menstrual cycle function, for example, we've seen takes longer. The longer it's not there, the longer it takes to come back online. And we really need to understand that from a variety of outcomes for the research and for the clinical practice. So are we expecting it to come back online in 2 weeks? And then if it doesn't, what do we do?
Right.
If it's going to take 4 weeks, if it's going to take months, that's something that we need to understand from whether or not interventions are effective, whether or not we need to do more one-on-one clinical care, how much support that athlete needs. And so really identifying some of these outcomes that are less studied in the REDS research as of 2024, and then going forward with more longitudinal and intervention-based work in order to have strategies that are evidence-based to help improve these outcomes and really not only prevent but treat athletes that are suffering from REDs and low energy availability.
Yeah. I think that would be great. I think along with that is the like you mentioned you experienced, it took a while to like get on board, is what is best practices for getting adherence to the plan for the athletes, and the fear around weight gain, or whether there's disordered eating behaviors and that kind of stuff too impacting. So yeah, very interesting area of research. Okay, I will be mindful of your time here since we're getting close on the hour. So I'll circle back to our two truths and our lie. Certainly could go on for like a whole nother episode. I feel like talking to you because you got so much good information in your brain there. Okay, so you were a footwear model. You ran a 4-minute, 34-second mile, and then you run on all 7 continents. I said the 4:34 mile was a lie, and Amanda thought the 7 continents was a lie. Which one was your lie?
You both caught me that I was fibbing with numbers, but Amanda was right. I have not run on all 7 continents.
Wow.
Unfortunately, not even close. I think I'm up to 3, not even 4, but I would like to check them all off one day.
Amazing. So you are incredibly fast though. You ran a 4:34 mile. That is amazing.
That is amazing.
Wow. Yeah. And what kind of footwear did you model?
And this one's funny because I've only really done it once, and my partner is a photographer and videographer.
Oh, cool.
And they were doing a shoot with, recovery footwear, and one of the models that was scheduled that day was sick. And I just get a call like, can you put on these shoes? Like, it was not a full thing, but I am in some footwear campaigns.
Amazing. Very cool. Very cool. Awesome. So let's see, where can people find you and follow along with your publications, research? I know you have a fantastic Instagram, if you want to give that a shout out. It has some great content on it.
Yeah. So I share my research and some other wonderful researchers. They're just trying to amplify the translational work with low energy availability in RED. So that platform can be found on Instagram. It's at Fed Collaborative, so at FED_collaborative. And then I'm hoping that I'll have a lot more updates on publications. So you can find those on places like Google Scholar or PubMed. If you just search my name, you can find the publications that we spoke about today. And then hopefully maybe you can have me back on someday and we can talk a lot more about the future work that is in process right now.
Definitely, definitely would love to have you back. If we could dive into all the new research you got going on. This has been a wonderful and amazing. Thank you so much for joining us today, Melissa.
You're so welcome. Thanks for having me.